Hello, everyone. I'm Monica Halapanawar, an adult psychiatrist at Seven Counties. Today, I have the pleasure of introducing Dr. Ali Talpur. He's the current fourth-year resident at UL Department of Psychiatry. I've had the opportunity to work with Dr. Talpur closely during his community mental health rotation at Seven Counties and also as his supervisor. His penchant for learning, his work ethics, and ability to be a team player are very noteworthy. He was born and raised in province of Sindh, Pakistan. He graduated medical school in 2015. He has secured distinction in forensic medicine as a third-year medical student. He has earned accolades as a resident of the year for inpatient psychiatry in 2022 and has served as a class rec representative in PGY 3 and 4. Dr. Talpur has a special interest in severe mental illness and trauma population. After his graduation, he will be joining Central State Hospital as an attending inpatient psychiatrist. Today, Dr. Talpur will be presenting the grand rounds on a very interesting topic, agitation and aggression on inpatient psychiatric units, which is a pretty common occurrence. Without further delay, I welcome Dr. Talpur on the stage to begin his presentation. Thank you.
Thank you, Dr. Halapanawar. I really appreciate the introduction and your help throughout the year with supervision during my long-term therapy clinic. And I really appreciate all your help that you've provided me and your support with the grand rounds as well. So as you all know, my name is Ali Talpur. I'm PGF4. So our topic, as Dr. Halapanawar said, is going to be agitation and aggression on inpatient psychiatric units. So before we start, I don't have any financial disclosures or any conflicts of interest for this grand rounds. And the other thing I want to mention is that although the topic is agitation and aggression on inpatient psychiatric units, I'm just going to touch a little bit on agitation, but the main topic would be the aggression that we see in our everyday practice on the inpatient psychiatric units. So without further ado, let's start. So the objectives would be to touch a little bit on agitation, and then majority of our topic would be aggression. We'll talk about the assessments, management, and the post-discharge care. The management for agitation and aggression is discussed together. We'll cover those together because it's almost the same that the modalities that we use as management are pretty much the same for both of these. So agitation. So agitation is defined in DSM-5 as a state of excessive psychomotor activity accompanied by increased tension and irritability, resulting in non-productive and repetitious behavior. Disequilibrium in emotional and behavioral regulation, abnormal increase in the verbal and motor behaviors, it is mostly indicative of underlying anxiety or a state of restlessness due to physical, psychosocial, or developmental factors. Poor impulse control is there, not necessarily with intent of harm, where it differentiates itself from aggression, and it can progress to aggression. Now, again, I would like to emphasize on the fact that agitation, aggression, and violence, they're on the same continuum of severity. Agitation is on a milder form of on that continuum. Aggression is more severe, and the most severe is violence. Risk factors, we have some modifiable and non-modifiable risk factors. Modifiable ones are medical conditions. We'll talk about that in a bit. Psychiatric conditions, substance use disorders, and psychological factors. Non-modifiable factors are traumatic brain injuries, developmental intellectual delays, history of abuse or trauma, history of aggression or violence, and history of cluster B personality disorders, and legal history. Psychiatric etiologies for agitation would be acute psychosis, acute mood episodes, substance intoxication, substance withdrawal, and other acute stressors. Medical etiologies that we usually see in our everyday practice on consult service are more important part of our agitation, because pain, I think the first one is the pain, and I cannot stress enough on pain. That's one of the most important and easily missed target. The reason that we see like an agitated patient. So delirium is another one. Neurological conditions such as seizures, cerebrovascular accidents, encephalopathies, infectious etiologies, UTI, pneumonias, encephalitis, meningitis, and to a lesser extent, like cardiac pathologies like coronary artery disease, ischemias, hematological disorders, metabolic imbalances are metabolic disturbances are more common, and then cardiac and hematological and endocrine abnormalities are also common, like thyroid abnormalities or adrenal abnormalities, to say. Screening tools, like there are several screening tools that we use to assess the severity of agitation. It's agitated behavioral scale, Richmond agitation sedation scale, Cohen's-Mansfield overt agitation, and brief agitation rating scale. I'm not going to go through all of those today, but the ones that I felt were more important ones, and I'm going to discuss those a little bit. So Cohen-Mansfield agitation inventory is a caregiver rated. It's mostly used in geriatric settings like nursing homes, and also used in acute and inpatient settings. So it's a pretty detailed, it's a 29 item based like a screening tool. And it occurs on the basis of like how many times a week and how many times a day or how many times an hour there are like behavioral disturbances, and it ranges from like verbal to physical agitation. So it's pretty detailed. We usually don't use this on the inpatient settings where it could be used. The other one is the behavioral agitation rating scale. This is more commonly used in the inpatient settings. And it has all the same things, but it's like a little bit less like verbal and then more like physical items mentioned there. And again, it's based on like how many times a week and how many times a day and several times a day or not. So how many times an hour. So this is pretty brief scale that we can use in the inpatient units, and it's commonly used on the inpatient units. I'm not going to discuss all of these, but these are some of the other ones. This is a recorded presentation, so you can always go back and look at these. The inter-rater reliability is pretty good for all of these. So these are all like commonly used in nursing home and inpatient settings. So let's jump to aggression, which I said is going to be a big chunk of our topic today. So it is defined by NICE guidelines from England as a range of behaviors or actions that can result in harm, hurt, or injury to another person, regardless of whether the violence or aggression is physically or verbally expressed, physical harm is sustained, or the intention is clear. And then American Psychological Association defines it as behavior aimed at harming others physically or psychologically. There are several different ways or various types in which it's divided or it's defined, but the most common ones are hostile or reactive aggression. It's a purposeful aggression with intent of harm and destruction, usually followed by strong emotional and impulsive components. You would see these in like more like a personality traits or somebody who's going through some mood component or mood disorder or acute psychiatric condition. Instrumental or proactive aggression is the primary aim is to obtain a desired goal, not inflicting pain or damage, and that's non-emotional. You would see this more commonly in a lot of personality traits. And the third one is effective aggression. Response to perceived distress can involve unrelated objects. That's usually the one that we see with patients with dementia, or we see with the patients who have some like underlying medical condition going on. This is again, like I'm not going to go through like and define everything again, but it's just like I would just go through violence, which as I already said, the agitation, aggression, and violence are on the same continuum of severity. Violence is just a part of aggression, but it's the more severe form of aggression. And American Psychological Association defines as an extreme form of aggression, such as assault, rape, or murder. So let's talk a little bit about neurobiology. So susceptibility of aggression it could be in a different context. If it's in the context of psychopathy, which is like a non-emotional response, having lack of empathy, it's kind of like a more severe form of antisocial personality disorder, I should say. It might result in instrumental aggression that you would see in antisocial personality disorders. If it's in the context of cognitive impairments or disorganization, you would see the aggression that you usually see in psychosis and deviant behaviors such as like rapes, murders, serial killings. If it's in the context of trauma, you would see the aggression triggered by the trauma and PTSD. And if it's in the context of emotional sensitivity or dysregulation, you would see it in a form of reactive aggression, such as in borderline personality disorder. So what happens, like whenever there is a stimulus that may trigger an aggressive episode, it's processed initially by the auditory, visual, and other sensory processing centers of our brain. And from these centers, the information is relayed to the early information processing areas, such as the visual and auditory integration areas, and finally to the prefrontal, temporal, and parietal cortices. So what happens if like a stimulus, if there is a like a problem with the auditory, visual, or sensory processing centers, or there's a dysregulation over there, so there could be a lot of sensory distortions or deficits there. For example, visual or auditory impairments, or like drug use, metabolic imbalances, and the other, all these acute psychosis, they all causes distortions and deficits in these areas. And a lot of schemas, negative schemas from the past experiences, traumatic experiences, or cultural or social perception of aggression is more processed in the early information processing areas before they go on for the process to be processed in the prefrontal, temporal, or parietal cortices, which actually work as a top-down break areas. So, what is aggression? Aggression is basically the imbalance between the top-down control and excessive bottom-up drives. Like top-down control involves the orbitofrontal cortex and anterior cingulate cortex, which are involved in like a social cues, more regulating the social cues, behaviors related to those, and then also involved in reward and punishments, and also to process the information, or maybe inhibit the actually to inhibit the negative responses in our brain. And the bottom up drives involve the limbic system, such as amygdala and insula, which are hyperactivated when we undergo any kind of a trauma, or we are undergoing like a acute aggressive episode. So we have some like neurotransmitters that may be dysregulated in the pathophysiology of aggression. So decreased serotonin or decreased innervation and activity in the orbitofrontal and the anterior cingulate cortices lead to disinhibited aggression. Reduced concentrations of 5-hydroxyindole acetic acid is associated with aggression and suicide attempts. There is a specific polymorphic gene on SLC6A4 gene that codes for serotonin transporters that is involved, and that could also be involved in aggression. Serotonin 1B is one of the receptors that is thought to be involved in the pathophysiology of aggression. Antagonism of serotonin 1B, serotonin 2, and agonism of serotonin 2C receptors have role in reducing aggression, and we'll talk about these when we go through the treatments. Increased noradrenergic activity is associated with hyperactivity to the environmental stimuli. Dopamine is involved in the initiation of aggressive behaviors. Monoamine oxidase A enzyme deficiencies linked to aggression. Lower activity genotypes have been correlated to antisocial personality traits. Dopamine 4 receptor, which is the target for a lot of psychotropics that we use, may be related to aggression, and we'll talk about that in a little bit more detail later. Increased cholinergic activity contributes to the hyperactivity of subcortical limbic regions, leading to increased irritability, which can indirectly be involved in aggressive behaviors. GABA A receptor modulators may enhance aggression by contributing to hyperactivity of subcortical limbic regions. Glutamatergic activation increases the possibility of aggression. So basically, it's the glutamatergic hyperactivation and GABAergic hypoactivation which may result in aggression. There is some evidence for other neuropeptides as well. Like, for example, the vasopressin has been positively correlated with aggression. If there is a deficit in oxytocin, that may result in amygdala hyperactivation and cause aggression. Opiates are positively correlated with self-directed aggression, like middencephalins. Testosterone and steroids may induce aggression, but the studies have not supported this fact. Like, a lot of times actually, although we know for we have heard this and we've seen this, that they may contribute to aggression, but really when you look at the studies, the relation is not pretty well defined. Reduced cholesterol might increase the risk of suicide and aggression. This is something very interesting that I came across. I did not look into a lot of detailed studies on that, but I think this is something to look into. if the reduced cholesterol actually might increase the risk of suicide or aggression. So something to look into. On the imaging, if you take the PET scans, if you do the PET scans, there is a decreased glucose metabolism in the temporal and the frontal cortices in aggression, specifically the orbitofrontal and the right temporal cortices. We know that orbitofrontal cortex is involved in the pathophysiology of aggression, so that makes sense. Volume reduction in the left orbitofrontal and the right anterior cingulate cortex is seen in borderline personality disorders. Prefrontal gray matter volume reductions is seen in antisocial personality disorders. Alterations in medial temporal cortex and hippocampus is also seen in antisocial personality disorders. And hyperactivity of amygdala is seen in borderline personality disorders, and that makes sense because they are very emotionally dysregulated. So the risk factors for aggression are, like, if we talk about the perinatal risk factors, there are birth complications, preterm birth or low birth weight, alcohol exposure in vitro, drug exposure, nicotine exposure, or psychological stress for mother. They contribute to that. Monoamine oxidase A genotype, the low expression of this genotype is related to aggression. Dopamine 1 transporter genotype is also involved. Catechol-methyl transferase that have valine and valine combination of amino acids is the genotype that is linked to aggression. Maternal attachment that is processed, like, that is related to hippocampus. If there is a DNA methylation in hippocampus, that may result in aggression or increase the risk of aggression. Glucocorticoid receptor gene methylation may also result in the same. Psychiatric disorders, we already know that. Psychotic disorders, mood disorders, anxiety, trauma or stress-related disorders, and intellectual disabilities, autism spectrum disorder, they are all can be the risk factors for that. Personality traits, antisocial, borderline, narcissistic, schizoid, and paranoid personality disorders are commonly associated with these. Stimulant use, alcohol intoxication and withdrawal, sedation, sedative hypnotic withdrawals, opiate withdrawals, and cannabis use, like illicit drug use, is also associated with the increases the risk of aggression. So the contributing factors, there are several contributing factors. We know about the patient-related factors a lot when we discuss aggression, but there is a lot more that may contribute to aggression. Environmental factors, like what is the unit structure in which the patient is admitted? Like, is the unit too crowded? Do they have like some privacy areas over there? We know that on 3 North, we have like atrium. It can serve as a good tap out area, what they call. So you can always like tap out, and you can, when you're aggressive, you can go to those areas and vent out a little bit. So having those areas is very important. Do we have those or not? That's one of the more important factors. Noise, how what is the, obviously it's an inpatient psychiatric unit, so it can become loud or noisy at times. So are there any measures to control that? The locked door systems, a lot of units, they actually, especially in the correctional settings, they also lock the doors at night for the patient rooms as well, which can also contribute to aggression because they feel like they're barricaded. And the healthcare system unit, what are the unit rules? What is the phone policy to use the phones? We know that we have specific times when we can use the phones. And if a patient is agitated, are we able to make that exception for them to use the phone and call someone in their family to talk to? That's something important to keep in mind. What's the hospital policy? What's the regional policy? This is beyond, this is a very complex thing. What are the policies that you can imply if you're trying to work with the patient? Can you make some exceptions or not? So that's important. We know patient-related factors like pathology, cognitive or emotional state of a patient at the time of aggression. That's important. And this is something the clinician-related contributing factors are very important. Like, what's the degree of communication? How well we communicate with our patients during the aggressive episodes and after the aggressive episodes makes a lot of difference when you treat someone with aggression. What's your attitude towards patient? We see a patient who's they're on the unit for quite some time, and they have some underlying personality traits. They are manipulative. So what's your attitude towards those patients? Like that counts as well. How good are you at de-escalation skills that can help your patient? And what is your own stress level? I think that's very important. Again, when we see a patient again and again being aggressive every single day when we walk in our unit, there is some stress level, even if we accept it or not. So how well are we able to regulate that stress level or deal with ourselves is extremely important. So this is an extremely interesting chart that that I came through. So when you look at this chart, you see that the patient factors that contribute to aggression on the inpatient units is rather small than the unit factors and the staff factors. We have already talked about the patient factors, so we're not going to go into all these details. But the unit factors are like higher bed occupancy, busy places on the ward, day and evening shifts. We cannot help that. Some of the patients have a good rapport with some of our staff members, and they obviously, when their shift ends, they have to go. And when somebody else comes in where they don't have a good rapport with, that also could contribute to somewhat to aggression. Unsafe environment, a lot of restrictive environment, lack of structure and inconsistent execution of policy. Smoking, it's not, I know that on our unit, it's like on our units that we rotate on, the smoking is not allowed, but there are some places, like, when there are like the smoking areas, um, less so in America, but there are some other places around the world that they have that. So that is also contributing to that. Staff factors like male healthcare workers are at increased risk of aggression. And then unqualified staff, like we have a lot of float nurse system. They are not qualified enough to deal with patients like psychiatric population. So, that contributes there as well. Temporary staff is also a contributing factor. Job strain and dissatisfaction, burnout levels, they all contribute. These are the staff factors that could contribute to the aggression on patients' part. The productive factors are like if there's a good team, good leadership, and if you involve your staff members in treatment decisions, I think they feel the importance of their role, and you can mitigate some of the stress and the burnout by doing that too. So that's something to keep in mind. But regardless, I mean, this chart is pretty interesting because the patient factors contributing to aggression is rather small. That's what I wanted to imply here. This is a paper, it's a very good paper. I'm just referencing it here because if you want to discuss the patient factors in great detail or go through the patient details and patient factors in detail, this is an article that you want to look at. But I have summarized the patient factors here. So the younger age have increased risk of aggression. And no significant difference in the genders. Male are relatively more were falling into aggressive groups in acute settings, and they were found in more in non-aggressive groups in forensic settings. Actually, that's interesting. There's no significant difference between the ethnicity, marital status. Like 4 out of 7 studies show that single patients were overrepresented. So not a big indicator of that. No significant difference in educated versus non-educated patients. One study showed the positive correlation with non-education, fewer years of education and aggression, but not good enough data there. Schizophrenia is associated with aggression. There was no difference in the probability that patient with affective disorder will be aggressive versus non-aggressive. Admission criteria: involuntary admissions go without question. They have some increased number of aggressive patients because they're admitted against their will. Aggressive patients had significant history of violence than non-aggressive patients. Uh, Self-harm or suicidal behaviors were more likely to be in the aggressive groups. History of substance abuse were more likely in the aggressive groups. And the legal history: the patients with history of violent convictions were actually less likely to be in the aggressive group. That's something that I found very interesting. So let's talk about epidemiology a little. So the mean prevalence of aggressive events is 54% on the inpatient units, ranging between 3 to 44. Somewhere between 0.5 to 33% of the inpatients cause majority of the aggressive incidents, which is pretty minority of the patients cause a lot, like a significant number of aggressive incidents. The highest prevalence is noted to be in the first week of admission, and the prevalence against staff of aggression against staff was like somewhere between 25 to 80%. Approximately 50% of healthcare workers were the victims of violence at some point in their careers. So there was a survey in the 1997 of psychiatric residents. They reported there was a 73% they reported being threatened, and 36% of them were actually physically assaulted. I could not find a better study for for the more recent years, but I suspect the numbers would be higher, unfortunately now. So neurocognitive disorders, Alzheimer's patients with Alzheimer's disease, like 27.8%, almost 28% of the patients with Alzheimer's disease can become aggressive. Almost 7% with MCI can become aggressive. 34% of hospital admissions in moderate to severe dementia are due to aggression. Prevalence of criminal behavior in the frontotemporal dementia is approximately 37%. Verbal aggression is slightly higher than the physical aggression, and that is generalized for all the various psychopathologies that we discussed. Verbal aggression is much more common than physical aggression. The contributing factors with this population is pain, depression, loss of family connection, poor patient-caregiver relationship, and men have slightly higher rate of aggression and behavioral disturbances. Intellectual disability, aggression is actually the main reason for these patients to be hospitalized, not their ID. Again, verbal aggression is more common. Socio-demographic and psychosocial factors contribute to hostility, more common in healthcare facilities than at home. Quality of care matters a lot. If there is a poor quality of care, that may instigate these aggressive episodes. Interpersonal interaction with the caregivers is important. When they have a good rapport with their physicians, there is less likelihood of aggressive incidents. Sexually aggressive behaviors is positively correlated with severity, which makes sense. A more severe ID are more related or exhibit sexually inappropriate behaviors. Hostile behaviors are seen with comorbid psychosis, personality disorders, autism, and depression. Self-harm is more seen in autism spectrum disorders. Acute psychosis is actually the major contributing factor of aggression on the inpatient units. 1/3 of the patients with first break psychosis exhibit hostile and aggressive behavior, more verbal than physical. One study indicated that 70% of the patients with first break psychosis had at least one aggressive episode in the period of 1 year. Again, the majority was the verbal aggression. Another study reflected that 7% committed violent act against others, mostly were self-directed or towards the property, and that's something to keep in mind. 46% had issues with legal system, according to another study that I looked at. Schizophrenia, schizophrenics have 4 times greater risks than general population, and the violence is associated with command hallucinations and persecutory delusions in the most cases. Almost 11 to 12% attempted suicide following a violent episode in one study. Prolonged and frequent hospitalizations increase the risk. So if they have a structured environment outside of the hospital, that significantly decreases the risk of decreases the incidence of inpatient hospitalization. That would help with their aggression as well. Prevalence in hospitalized patients was somewhere between 15 to 53%. Verbal aggression contribute to the 70% of the cases, as I said. More common in males. Suicide attempts were more common in females. Illicit drug use increases the risk. 20 to 65% of schizophrenics use illicit drugs, by the way. So that's a big number, and that definitely contributes to aggression. So lifetime prevalence of bipolar 1 disorder, lifetime prevalence of aggression in bipolar 1 disorder is approximately 25%, and bipolar mixed is approximately 12%. Usually during the acute manic episodes, but high risk is also estimated when they're in remission. Mania with psychosis further increases the risk. Psychomotor excitation is related to increased aggression, more so towards property. That's what I have seen in the studies. Serotonergic hypoactivation and prefrontal dysfunction play a major role in the impulsivity and hence increased risk taking behaviors, including aggression. In major depressive disorder, the aggression is more like self-directed, it's self-inflicted. Impulsivity, alcohol use, and the risk of suicidal behaviors, they're the common factors. Anxious depression has a way increased risk than any other subtypes of depression. Alcohol use further increases the risk. So the alcohol use was 32% in a depressive episode. If somebody who was depressed versus non-depressed individual, which was 9%. Um, Obsessive compulsive disorder, aggression and hostility were positively correlated with hoarding, inhibition of avoidant or ritualistic behaviors, and the severity of the symptoms that contribute to aggression. Interpersonal conflicts and hostile behaviors are more common in this population. One study showed that 27% of the OCD patients had SI and 33% had actually attempted suicide. The number of attempts for suicide is quite higher than we can think about. Personality disorders, it's more common in cluster Bs, and paranoid personality disorder, which is a cluster A subtype. Cluster Bs are 10 times more likely to commit crimes and 8 times more likely to be in prison compared to other personality disorders. A greater risk of hostilities with borderlines, antisocials, which is 4 times more than the other subtypes. 73% of the patients with borderline personality have at least one aggressive episode during 1 year period. Borderlines have reacted more commonly. We've talked about this a little. So reactive aggression is more common in borderlines, and instrumental aggression is more common in antisocial personality populations. Narcissistic personality disorder is actually it's a significant predictor of violent behavior in clinical and forensic populations. Something that we don't come across a lot of times, or we easily miss. I don't know, but that's something to keep in mind with this population as well. Low and unstable self-esteem is related to hostility and violence in this population. Substance use disorder, substance use is the only contributing factor that accounts for only 2% of the cases of aggression on the inpatient units. Comorbid diagnoses increase the risk further, like schizophrenia, mood disorders. Alcohol is the most commonly associated with aggression and violence. Heroin has good evidence indicating positive correlation with aggression. 43% users have attempted suicide in the past, and withdrawals can also contribute to increased unintended aggression. Regular users of cannabis are 3 times more likely to have interpersonal aggression, almost 1 time more likely to be victims, and almost 2.5 times more likely to be both perpetrators and victims. So it's not a mild drug of abuse at all, which is the common perception. Withdrawal has a stronger evidence for anger and hostility than intoxication. Stimulant use increases the risk. Cocaine has the strongest evidence for physical, sexual, and psychological aggression, and it's been replicated in studies. Hallucinogens have actually negative correlation with aggression, and which I believe is why they are more commonly used in with acute stress disorders and trauma populations in association with psychotherapy. So assessment. Before we jump into assessment, I think it's very, very difficult to predict a potential violence. Let me keep it that way before we begin. But that does not mean we can just leave it there. There are some factors that we have to keep in mind when we're assessing those patients. Patient factors, specifically the history of violence, is a very helpful predictor if the patient can become potentially violent. Signs of impending violence are tense posturing, angry demeanor, restlessness, provocative behaviors, manipulative behaviors, demanding, verbally condescending, threatening to leave, subtle aggressive behaviors like slamming doors or throwing pillows in their room. That could be a sign of impending violence. So there are some screening tools. I would not go through all of those. I would just discuss like HCR20, which is believed to be the gold standard for like a screening tool for aggression. We don't use it often. I know that the psychologists use this tool a lot, but it's gold standard with aggression, in aggressive population. So this is, again, I'm not going to go through this. You all can go through this later on, but these are different scale screening tools that you can use. They all have their weakness and strengths, and something to look at if you have some time. At CR20, it's a 3-category and 20. It's based on 3 categories and 20 items. Each item scored 0 to 2. Maximum score is 40. It's most widely used tool worldwide. It is used to predict violent behaviors, commonly used in patient psychiatric, forensic, and correctional settings. So it's based on the patient's history, previous violence, young age, substance use problems, history of psychiatric disorders, psychopathy, personality disorders, and clinical scale, like what is their level of insight, what is their attitude towards their diagnosis? Are there any active symptoms of any psychiatric pathology? And are they impulsive? And then there's the third one is the risk management scale, like if they have appropriate plans after discharge, they have the exposure to destabilizers, or what is the status of their personal support outside of the hospital. So all these things count, and I think it's a pretty decent tool to use. So management is based on non-pharmacological, pharmacological, and interventional basis. So there are four main objectives to that. The number one is that you have to ensure the safety of the primary patient, staff, and the other patients in the area when something like that happens. You have to help patient process their emotions and regain control of their behavior. Avoid the use of restraints whenever possible, and avoid coercive interventions whenever possible. And I cannot stress enough on that. I think that helps a lot in my own personal experience as well. So a clinician's approach, and this is more so like for everyone, for the nursing staff, for the doctors, for the technicians, like what we have to do as a team. So rapid assessment and decision making skills are important. You should be able to quickly decide what you want to do with the patient. Use the verbal de-escalation as a first line tool regardless. That's out of question. That's always comes first. Even so, if you're like your patient is extremely disorganized, at least give a try for a verbal de-escalation. And if it's not successful, then you can move on. Environmental planning, like what measures you have to take. You have to move the chairs around. You have to make some more space for the patient. You don't have to like make the environment overcrowded at that time. So that's something you have to quickly think about. Um, you have to assess for rapidly changing patient priorities. You have to ask them what they want. Their needs and wants are important, more so their needs than their wants, and see if you can work with the patient that way. And recognize and control your own emotions and countertransference. And I think that is very important with this patient population, regardless if we're working on the inpatient unit or we're in the emergency psychiatric services. Our own emotions and countertransference matters a lot in our decision making. So I think if you're able to counteract and work on our counter transfer towards some of the patients, that would extremely be helpful for the patient. Voluntary medications, offer them voluntary medications whenever possible. Involve the doctor if you're not the doctor, and see what you can work with. Accept the patient's behavior as the manifestation of their mental illness. That will ease up on a lot of things and a lot of decision making or clouding of a decision making if you're having any. So if you do that, that helps a lot. Physical restraints and involuntary medications should be considered as the last resort. Verbal de-escalation, you should respect their personal space, avoid provocation, establish a verbal contact with the patient, be very concise, simple, and reiterate if you have to, especially with the patients who are very disorganized, you have to reiterate yourself several times. As I said, identify their needs and wants, see what they want, what they need. Actively listen and repeat back. That gives them a confidence that they're being heard. Agree to disagree. You can be straightforward to the patient, set the limits with them, lay down what the law and the policies of the unit are, and then try to talk to them with this, and then respect their autonomy and offer different choices. See what they are willing to accept and what not. And debriefing is important. I think this is something that we should be using more than we are. Debrief with your team, with nursing staff, with your technicians, that what could be done better and in certain situations, or what you've done so far and what could be done differently in the future. And debriefing with the patient is also extremely important. When patient, not in that very moment, obviously, if you have to give them some PRN psychotropics, you give them that. And when the patient is back to their baseline, I would say that go and talk to your patients and see, and try to understand and try to ask them what went wrong. What was something that went off with them and they had to give you medicine, and explain them your rationale that why you had to give them the medication. That helps. I have tried that, and that helps a lot with building a very strong therapeutic alliance with your patients. Restraints and seclusions, they are to be considered when verbal de-escalation fails. Seclusion is preferred, they take priority over restraints. Indications are imminent dangerousness to self or others, or their non-redirectable destruction to property. The restraints and seclusions can be contraindicated in some instances, and we have to be mindful about that. If a patient has hemodynamic instability, they have suicidal behaviors or gestures or self-injurious behaviors, or in the cases of overdose, especially when you put patient on seclusion, I mean, we have to be very careful, and we have to keep these things in mind. Monitoring is important. Frequent monitoring is necessary for any kind of like paresthesias. Are we like tight? If the restraints are too tight, we have to be very careful. If their nerves are not being compressed, hemodynamic obstruction is something that you have to keep in mind. Pressure sores, some patients are like extremely medication naive. You give them and they're like completely out for almost 24 hours. You have to make sure that they don't have any underlying risk factors for pressure sores. It's less likely in the emergency settings, but still, like if your patient is for example, catatonic, they're not moving a lot on the unit and they become aggressive all of a sudden, and then they're on the bed for the next 24 to 48 hours. This is something that you should look for. Rhabdomyolysis is important, and the need for the using restroom is important. You have to keep that in mind. Patient is calm, and you have to respect their privacy there too. If there is extremely violent patient and there's a higher level of resistance, it's for more than 5 minutes, we would recommend you do like a full trauma evaluation, full cardiac evaluation, and monitor for hypothermia as well in your on your unit. And then pharmacological interventions, there are some basic rules to avoid sedation, focus on rapid tranquilization. Tranquilizers are always better because you still have a chance to talk to your patients when they're calmed down. So try to avoid sedating them whenever possible. Rapidly acting agents are preferred with also with the short duration of action and with minimal side effects. Something that we encounter in these situations is that we often like, I mean, we have good EMRs that indicate or pop up warning that the patient is allergic to something, but that is something to keep in mind. If they are allergic to something or there's a drug interaction with what their medication are, try to look into that before you give them the medicine. That would be helpful. So this is basically the joint British Association of Psychopharmacology and National Association of Psychiatric Inpatient intensive care units evidence-based consensus guidelines from UK. They base these guidelines based on systematic reviews and randomized controlled trials. They look into a lot of studies, and they focused on like almost like 2,000 episodes of acute disturbances, and they looked at different aspects of that. Like the 90% of the cases, non-pharmacological interventions were used, and I will discuss that. I have summarized that, and I will discuss that in a little bit of a detail at what they use and how they use it. So restraints were 3 times more likely to be used with parenteral administration, which makes sense. Oral medications were used almost half the times. Parenteral medication was used in 43% of the cases, mostly IM. Combination of oral and IM or IV were used in 7% of the cases. Oral benzos were most commonly used, lorazepam in more than 90% of those cases. Antipsychotics alone were used in 12% of the cases, and haloperidol was used in majority of those cases. Promethazine is something that we don't use, and that was used alone in 2% of the cases. And when you talk about the combos, like oral benzo and antipsychotics were used in 15% of the cases, and oral benzos and promethazine was used in 5%. IM benzos, 60%, 67% of the cases, as an only IM medication, like 39% of the cases, and lorazepam was used in 99% of the cases, and median dose was 2 milligrams. IM antipsychotics in the 50% of the cases, and as an only IM medication in 18%. Haloperidol again was used in 67% of the cases, and surprisingly, aripiprazole was used in 14% of the cases, more so than olanzapine or and the others. IM promethazine was used in 7% of the cases. Combination IMs were used in 381 episodes. Benzo and antipsychotic combinations were used in majority. Most common was lorazepam and haloperidol, and IM promethazine and IM or plus IM benzo or IM antipsychotics were used in 4% of those cases. So let's talk, and this is a summary of what they mentioned in their guidelines. So for lorazepam, like oral lorazepam was effective, so we can use that. And then IM monotherapy is like less effective than antipsychotics as a monotherapy, but more sedating than IM aripiprazole in one study. And in combination, like more sedation was seen in the short term with along with like when they used with haloperidol, like 15 minutes to 1 hour, and there was no difference in medium term, like on between like 1 to 2 days, and the level of sedation was the same regardless. It was a low quality evidence, so we don't know a lot about that. IV lorazepam has a better tolerability profile. The sustained results were seen at 30 minutes as well. And adverse effects were oversedation, ataxia, cardiovascular collapse, increased falls, disinhibition, and respiratory depressions, especially with the parenterals. Midazolam, the buccal midazolam is very effective to use in these populations. It has a quick, it works well. It's IM monotherapy, it has a quicker time to sedation, no sustained effects. But because it's quicker and it has a very short acting, so it usually needs a rescue sedation, which means the following, like rescue sedation means like you have to give another medication sometime to keep the patient calm. In combination, there was one small study that will use haloperidol and midazolam with better medium-term results, like between 1 to 48 hours. Again, the quality was low. And then for IV, the rapidly sedating than any benzos or antipsychotics. There were no sustained effects, but there were some like the same side effects that we see with lorazepam, but there was one randomized controlled trial where that showed some increased risk of active airway management when you give IV midazolam. Aripiprazole there is some evidence for the use of aripiprazole orally, like supported by the adjunctive lorazepam use. The medium dose is like 10 to 15%, 15 milligrams a day. And IM monotherapy, there's a very limited and poor quality evidence, less sedation, better tolerated because it's an overall better tolerated antipsychotic. We don't have any results on IM or IV, IM combinations or IV like monotherapy for aripiprazole. Droperidol, the oral uses has limited evidence. Lack of use is due to QTC prolongation. And the IM monotherapy, it has similar to haloperidol, but more sedative. Recent studies suggest better tolerability in the light of QTC prolongation. And the maximum dose that you can use over 24 hours is somewhere between 5 to 10 milligrams. And that's recommended. You can go a little bit higher, but not a lot. IM combinations, like some evidence is there with the use of midazolam with increased risk of adverse effects. And IV is similar to IM. So there's no much difference. Sedation, dystonia, respiratory depression, QTC prolongation, and NMS is common with droperidol. Haloperidol, there's some evidence of oral, no superiority over second generations. That's something very important to consider, especially in the population where they have increased risk of EPS or NMS. Studies have shown there's no superiority over second generations. So you can easily use second generations, or they take precedence over haloperidol. IM monotherapy, it has a better sedation, but more risk of EPS. Again, there is no superiority over second generations in that use. In the combinations, promethazine, longer lasting sedation, rapidly effective, better safety profile. And with lorazepam, it has no superiority over other combos, so you can use either with promethazine or lorazepam. And for IV, there are no randomized control trials, more likely to cause cardiovascular effects, but we commonly use IV haloperidol in patients with agitation, especially on the medical unit when there is someone who's very delirious. And it helps, and it's less riskier that way. Dystonias, EPS, QTC prolongation, and seizures with IV are common, NMS, of course. Olanzapine, there is some good evidence for olanzapine oral use. IM monotherapy is rapidly acting, better tolerated, less risk of EPS and QTC prolongation. And in my opinion, it's definitely better than haloperidol. But it is required more over time. Like there is some rescue sedation that is required with olanzapine. And IM combinations, you have to be very careful giving it with like any benzodiazepines. We usually not prefer that. We at least try to make sure they're like 3 to 4 hours apart. But if it increases the risk significantly if there is a risk of alcohol intoxication on the background as well. IV has some rapid sedation. There are limited studies due to perceived risk of post-injection syndrome. I can't think about that name. So there is not a lot of studies on IV olanzapine. Quetiapine and risperidol, there is evidence for oral use, with the long term with quetiapine, like 6 weeks to 1 year, it helps with aggression. Risperdal has some evidence as monotherapy, but it's more better tolerated and has a better response when it's given with either lorazepam with lorazepam. So there are some of the other medications which I want to discuss, which are not, which they have not discussed in that paper, but I'll just quickly skim through those. Promethazine is a strong histamine receptor antagonist and a moderate muscarinic receptor antagonist. Onset of sedation is 20 to 30 minutes. Tmax is 2 to 3 hours. 25 to 50 milligrams PO or IM, like 8 times, like three times a day, is could be tolerated well. It's very successfully used in combination with Haldol, so there are no absolute contraindications for its use. It's used with IM Haldol, especially to mitigate the extrapyramidal symptoms and the risk of NMS with Haldol. But you can use it as a monotherapy as well, and there's some evidence for the use there. Brexpiprazole, it's recently approved, FDA approved for agitation in Alzheimer's disease. There were 12-week randomized, double-blind, placebo-controlled parallel studies that were done. One was the fixed dose of 2 milligrams, and the other one was flexible dose with 0.5 to 2 milligrams. But the results were that 2 milligrams per day had the potential to be efficacious, safe, and well tolerated with improvement in agitation in Alzheimer's disease. So this makes me think, like, if brexpiprazole, if that's not available, or it's too costly for the patients, I mean, the other off-label use that you can use, you can always use aripiprazole for these patients or anybody per se. Loxapine is it's a strong antagonist at D2 and certain 2A receptors. It's approved for the use in acute disturbances in schizophrenia and bipolar 1. Tmax is 2 minutes, which is pretty impressive. Recommended dose is somewhere between 4.5 to 9 milligrams a day. And then higher doses are approved more for mood disorders than psychotic disorders. Optimal for use in a mild to moderate disturbance because it's inhaled and it's extremely hard to give for someone who's severely agitated or aggressive. And the contraindication in these patients with respiratory conditions, not the absolute contraindications, but relative. So you have to be careful if your patient has a respiratory condition. Clozapine, it's a D4 receptor antagonist, and the studies have replicated that D4 receptors have a very strong role in aggression, and it blocks D4 receptors very strongly than it does bind to D2 receptors, which favors its use in aggression. There have been few open studies and 2 randomized controlled trials that have used the favor over risperidone, haloperidol, or even olanzapine. And there was no significant difference in the length of hospitalization in those studies, but the incidence of aggressive episodes went down pretty significantly in the ones who got clozapine. There are a lot of limitations to use clozapine, of course, like, when that is the case, that with our population with schizophrenia and someone who comes with acute psychosis as well. The lab draws, RAMS program, there are a lot of limitations. So I think that is something that is a barrier to use clozapine, especially when you're targeting aggression. But I still think it's one of the very good medicines to use in aggression, especially for someone who has a sustained aggression. And then esinopin, strong antagonism in serotonin 2A, 2C, and 7 receptors. It has a 1 randomized controlled trial, which was placebo-controlled, significant improvement in PANSS EC score at 2 hours. Dose ranges 10 to 20 milligrams per day in divided doses. Off-label use in clinical practice supports its use. I think it's a pretty good medicine. I like esinopin a lot, using it in anxiety, and it also helps with aggression. Again, the problem is it's sublingual, and the patient has to be somewhat receptive if they agree to take esinopin or loxapine. Chlorpromazine has a strong antagonism at D2, H1, and D3 and alpha-1 receptors. There's a poor quality of studies for its use. One study actually compared it with Haldol, and there was not much difference when it came to additional doses. Actually, 2 people in the chlorpromazine arm developed hypotension, and 1 person in the same arm developed status epilepticus. There are poor quality of studies, but we have seen in our practical implications that chlorpromazine works when other medications are not working for someone, especially in EPS like emergency psychiatric services. And the maximum daily dose for chlorpromazine is 2,000 milligrams in 24 hours if you're giving it PO, and 400 milligrams in 24 hours if you're giving IM. So the dose range is pretty strong. So you can think about that. But again, the problem is QTC prolongation. So you have to keep a watch on that too. Lithium, I just mentioned it there. There's some evidence for use in the Alzheimer's, dementia, and with behavioral disturbances. There's weak evidence for use in other conditions. Anti-suicidal properties that lithium has may contribute indirectly to reduce self-directed aggression. Pro-BDNF properties may have some role in like neuroplasticity, and may decrease the proactive aggression associated with personality disorders. But I don't know. That's a question mark. So I just threw it there. I wish there were more studies on lithium in acute aggression, and that would have been wonderful. Valproic acid has a good evidence in the use of behavioral disturbance secondary to mania. Some uncontrolled studies have also supported use in schizophrenia as anti-aggressive agent. Regular use in mood disorder decreases the need for acute treatments. We all know that valproic acid is excellent in that case. It's more effective when combined with second-generation antipsychotics. And there is some evidence for using IV loading doses. I know we don't do that a lot, but IV loading dose for 20 mg per kg, I have seen there's a robust improvement in aggression when you do that, or even in acute mania. But that's not preferred for a lot of reasons, and I don't want to go into those details today. Ketamine, there was a small retrospective review that supported the use in emergency situations with IM ketamine. Tachycardia and hypertension, which are common side effects with ketamine, we should keep those in mind. And with the use of IM ketamine, it actually is, there's increases for these. Almost 62.5% of the patient required additional agent on top of ketamine whenever it was used. There was another study that compared IM and IV ketamine with haldol, haloperidol, midazolam, and lorazepam, all IM or IV and in combinations. So there was less agitation at several checkpoints than others, less adverse effects and need for additional doses, and doses were actually higher than we use for treatment-resistant depression. It was almost like 1 to 2 milligrams per mg per kg IV and 4 to 6 mg per kg IM. The treatment, there were small treatment group sizes, so does not give us a lot, but something to think about. ECT has a good evidence for use in agitation and aggression secondary to dementia. It's beneficial for treatment refractory cases, and it could be used for prolonged and severe manic and psychotic episodes, which are associated with aggression. And the treatment of acute mania and psychosis indirectly addresses the associated aggression. So, and someone who has underlying aggressive personality, and on top of the fact that they have some underlying psychotic and psychiatric conditions such as bipolar disorder or schizophrenia that is treatment refractory to some extent, I think ECT could be a good target, all of those. So coming back to our paper that we just discussed, there's evidence and the strength of recommendation they have mentioned, and there's an algorithm that I have referenced from their paper. So I will go through that. So the evidence 1A and 1B is based on the randomized control trials, and it's in the descending orders, with category 4 having the weakest evidence, and it's based on the clinical experience. And strength of recommendation is again AAB, and they are based on the randomized control trials. And C and D are more like in the descending order from the expert opinion, clinical experiences, or from case studies. And something called S is the standard of good practice, and it again comes from the experience they have. So that's basically their algorithm, and we'll go through this. There were fundamental principles, multidisciplinary approaches, effective interventions, treatment individualization and choice. All those things are considered, like their patient's physical health, mental health, what is their level of risk, and what is their level of engagement. You should keep all these things in mind. Consider the other factors as well, like what is the level of intoxication, if they are at all. What is if a patient is pregnant, what you should do. Medical frailty and physically compromised patients, you should be very careful about those. So all are these fundamental principles that you should keep in mind, and it's highly individualized based. So you have to think about that. And then there are pre-RT de-escalation. RT is a rapid tranquilization. So pre-rapid tranquilization de-escalation, self-control techniques, continual risk assessment, respect patient space, all of them have some weaker evidence for their implication, again, because these studies were done in like acutely aggressive patients, so that might not be helpful in those that population. Like it includes like a passive intervention, empathy, reassurance, negotiation, reframing event for the patients. So all of them have a slightly weaker recommendations because again, the population that this study was done was very different. It was more severe population. So pre-RT oral and oral inhaled or buccal. So oral inhaled loxapine has a very like excellent evidence, a very strong evidence. It's 1B and strength of recommendation is category A. Buccal midazolam has somewhat weaker evidence in that. Oral lorazepam has quite a weaker evidence than we would think it would. And oral promethazine is based on the standard of good practice. But here is something very interesting in this part, like oral aripiprazole and oral olanzapine and oral risperidone have almost similar evidence, which is very strong and stronger than oral haloperidol and oral quetiapine. So I know we don't use aripiprazole a lot in the acute settings, but they have seen it. These all were like randomized control trials, systematic reviews on different trials. So they have supported the use of oral aripiprazole in acutely aggressive population. So in the intramuscular monotherapy, the lorazepam had a better evidence as a monotherapy. IM promethazine also had a good evidence. IM aripiprazole again has a very good evidence over here. IM droperidol and IM olanzapine, all of them have a pretty strong evidence as monotherapy. As a combinations, IM promethazine and IM haloperidol had a strong evidence, and IM lorazepam and IM haloperidol also have a pretty good evidence in a combination. In intravenous, resuscitation settings only, it should be used where you have resuscitation settings. You're all prepared for that, especially on the methcyclors. So if there is any complication, it should be addressed quicker. IV lorazepam and IV midazolam has a very strong evidence. IV droperidol has a good evidence, and then IV olanzapine has a weaker evidence, and for the reasons we just described. And then when there's a non-response to treatment, you can consider a comprehensive case review. You can consider zuclopenthixol acetate. It's a first generation antipsychotic. It's pretty. I'm from Pakistan, and it's pretty commonly used over there. And it has some. I have seen when I was working there, I have seen some good evidence with that. We don't use it in US. But it has some good evidence, but also increases the risk of NMS and EPS significantly. So you should be careful, and which is why I think it's lower. It has a weaker evidence, and it's only used as a last resort if nothing else is working. And of course, consider ECT. We don't have a very good evidence, but treatment refractory cases, it should be helpful in those. In pregnancy, we have lack of randomized control trials due to ethical reasons. Avoid drugs that may accumulate in the tissues. Drugs with shorter half-life are preferred. Acute short-term use of benzos and antihistaminergic is preferred. I'm not sure if in the last trimester you could, depends on what happens, but the evidence we have, it's more for the first trimesters rather than the last trimesters because of the withdrawal symptoms in the baby. Haloperidol has some safety data, so that could be used, and it's preferred over any other antipsychotics. And one thing we have to remember is that teratogenic effects are dose dependent, and the dose response curve is pretty steep. So you have to be very careful. Start with the lowest dose possible, and see if it works. And again, like the non-pharmacological measures and restrictive measures are preferred in this population. Alcohol and benzo intoxication, you should be meticulously using benzos, but they're still preferred. You can use those. Watch if the patient has used any other respiratory depressants, and you have to be extremely cautious when using antipsychotics in this population because it lowers the seizure threshold quite phenomenally. And then impact on cardiac rhythms is also replicated in the study, so you have to be careful about that. may complicate the diagnosis if it's drug-induced or primary psychiatric condition. It's low yield. I mean, when there is a person who's acute, very aggressive, and you don't have other options, you may just go for it. Alcohol and benzo withdrawals, short-acting benzos are preferred. Parental haloperidol is safe to use. Thiamine replacement is extremely important. Gamma hydroxybutyrate withdrawal, which is, I think, it could be a potentially life-threatening withdrawal. It involves GABA B receptors, so baclofen and addition of benzos remain the treatment of choice in that population. Let's talk about the post-discharge care a little bit. These are the resources. Aggressive Behavioral Control Program was introduced in like a regional psychiatric center in Saskatoon in Canada. It's a 6 to 8 months program for the high risk and high risk offenders for which other interventions have not been used. So it's primarily based on CBT. And it has shown some data to like support its use after the patients are discharged from the hospital or they're in the correctional setting. I have not looked into all of these in a great detail, but these are something to consider. There's another one, community-based multiple family groups to prevent and reduce violent and aggressive behaviors. It's based on the GREAT family programs, guiding responsibility and expectations for adolescents for today and tomorrow. That's what GREAT stands for. It's a 15-weekly program. It is extremely helpful in high-risk youth and young adults. So it is also based on CBT and several other techniques. It's multi-system approach for them. That whoever is at a high risk for violence, those programs can be very helpful. Community-based violence intervention and prevention. It's relatively new. It was introduced in 2022 by the current government in US, and it also based. It is a target for someone who's high risk out in the community. So there are some programs. There are some like multi-system approach programs that could be helpful for at-risk patients. There is another one, Stop Now and Plan, which is called SNAP. It's a cognitive behavioral model, and it's again target for the youth. I know this. My talk was mostly focused on adult population, but these are some of the resources that can use. I could not find a lot of details about the post-discharge care for some of these patients, but I think it's extremely important. The caregiver burden is something that should be kept in mind with these patients, like whoever have their families. They're dealing with two different things. They are dealing with someone who has a diagnosis of schizophrenia with acute psychosis, and then or mania in the light of like bipolar disorders, and then you have someone, and the same person has some aggression going on at home. They're breaking the properties, they're hitting their parents or siblings or anybody at all. So it causes a significant caregiver burden. And like the social media groups, like Facebook groups or some in-person groups that are out there for these caregivers is extremely important. I think they should be emphasized more when we are about to discharge our patients from our units. And with the help of our social workers, I think we can do great in that aspect of patient care as well. I think that's it. That's all that I have to talk about. Thank you so much for listening to my presentation, and I will now take any questions.
Thank you, Dr. Talpur. We'll promote some of the attendees to panelists so they're able to ask their question, but please use the raise hand function.
Okay. Dr. Wong, you have a question?
Hello.
Hi, Dr. Wong.
Hi, Dr. Talpur. Thank you for your excellent presentation. I wanted to ask you a question about IM ketamine. Have you you talked about it briefly? Have you had experience, with your patient needing that at all? Because I recall at some point in residency, I had a patient who was restrained for a while after various IM injections. and I had to send her to the emergency room for IM sedation, because I think that's something that requires more intensive cardiovascular monitoring and wasn't appropriate for EPS setting. But just curious.
No, I think that's a very good question, Dr. Wang. I think in my experience, I have not used it, but I think like because these guidelines, consensus guidelines, were also based on the ICU settings. So I think they have in England or in like Europe, they have used in the ICU settings, and I think it's helpful. But again, the systems, as I said, like it's short lasting. So you may need some rescue sedation with whenever you consider ketamine for these patients. But like, no, to answer your question, no, I have not had any personal experience using ketamine. Dr. Oliva?
Yeah, a really good presentation, Ali. My question more so goes along with sexual aggression. I know you touched on it a bit, and there is a long history of somewhat controversial treatments for sexual aggression, including hormone therapy and the like. Did you research much into treating sexual aggression specifically, using things like spironolactone or other things for treating sexual aggression, or that you look into much into that?
I think that's a great question, Dr. Oliva. I have not looked into a lot of details because this becomes a controversial topic to discuss. But
Yeah.
again, like whatever I have looked at in my experience is that like the sexual aggression, like what is the underlying cause of that sexual aggression? If it's like if they're sexually aggressive and they have like some underlying intellectual disability, or they're extremely psychotic or extremely manic, at that point, like, this is something that you can think about. But for like, again, I mean, because it's a hormone replacement therapy, it has to be longer term. And given the extent of how a patient, what is the extent of like sexual inappropriateness with the specific patient? Have they been involved in any legal issues, or there are some like, legal issues going on with them? At that point, I think in my opinion, it may warrant the use of those. But if it's like underlying due to like underlying, like maybe someone who's having antisocial personality traits or their criminal behaviors, I think in those cases it becomes questionable to use those, because those are like a criminal acts and they should be considered and treated as a criminal acts rather than like there's so much we can do to treat that. So I think that in that aspect they would be more criminal based than based on any psychiatric pathology.
Yeah, and we were talking about this the other day when we were on Norton Consults. A month or two ago, I was consulting a patient with a history of being pedophilia. He was in prison for a decade due to molesting a child, and now he'd become disabled and need long-term placement. It was a waiting placement, and became a whole mess because of his legal history. And while he was at the hospital, he was making sexually inappropriate comments and some behaviors. And they consulted me, say like, what do we do? I'm like, well, he's not psychotic, he's not like intellectually disabled, he's a criminal. I made the recommendation you could switch his Lasix to spironolactone because that might block some of his testosterone. The primary care team didn't want to do that, understandably. But yes, there's limited resources in those cases. I do agree that in people with intellectual disability, people who are psychotic, who are sexually acting out, there are treatment options, but I don't think we're really well trained, especially in hormonal treatments. I've never used hormone treatments for people with sexual aggression. And overall, I think it's a very interesting and complicated, controversial topic in general.
Yeah, I think it falls into that gray area, like when like there's a lot of liability for a decision that you take with these patients. So, yeah.
Sure.
Dr. Pawa, I think, had a question.
Okay.
Yeah, hi.
Hi,
Thank you, Ali, for such a comprehensive talk. I have two questions. One is on Thorazine that you talked about. I think you said the dose is 400 milligrams. I think that's the maximum dose and not the average dose. So we usually use 50 milligrams, but I wanted to know, what are the doses that are used, generally? Is it just 50, or do we give, can we give 50 in increments till the patient is stable? So there was a time when we had Haldol shortage. I think it was pretty, transient time. But in such cases, we do use Thorazine. And with the limited, we usually go to 50. So can we go higher, or is it usually incremental dosage that we give with an agitated patient if we are using Thorazine? My second question. Okay. Yeah, I'll let
Go
you
ahead.
answer that.
Sorry. Go ahead. Go ahead with your second one.
Okay, my second question, I know you briefly mentioned about Depakote IV loading dose. So as far as the research is there, I wanted to know if there's a specific population that it has been studied on, other than acute mania, in patients on consult service when they are acutely agitated with other conditions, epilepsy or a head injury, or patients in ICU. I mean, that's where we struggle more than acute manic patients that we can manage an inpatient setting. And I think this is something that can be really useful on the consult service in that population, if there's anything that you came across while studying. And one last, I'm sorry if you did discuss about the phenobarbital. We've been using that, and your comments on that and the dosage.
Okay.
Thank you.
Thank you. I think those are all great questions. To answer your first question, there is no clear guidelines on how often you should give Thorazine or chlorpromazine. In my experience, I have used like 50 milligrams after every couple of hours, 4 to 8 hours, 4 to 6 hours, and that has worked fine. The problem with chlorpromazine is that it's a pretty strong binder at the alpha receptors as well. And it also causes quite a significant QTC prolongation. The maximum dose is 400 milligrams per 24 hours for the IM formulations, but I would be very careful and I would go up slow when I'm treating those patients because of the same reasons, because I don't want them to collapse. And then I don't want them to have any QTC prolongations. If they are completely out after they get chlorpromazine, I would at least get EKG. That would give me a pretty much idea about what their QTC levels are. I haven't come across that if those side effects are also dose dependent. So you can, I think in my experience, to answer your question, I have gone 50 milligrams every 4 hours as well in some of the patients, but I have, in my experience, have never gone more than 150 milligrams total for those patients, because I think it works. It's pretty strong binder on histaminic receptors as well as the alpha receptors. So it works on the much lower doses in my experience in some of the treatment resistant patients when it comes to aggression. I have used it a lot in EPS. So I would, in my opinion, would say that, it's safe to use every 4 to 6 hours, 50 milligrams every 4 to 6 hours. To answer your second question, I have looked into the studies. I don't have my personal experience with the use of IV Depakote, but there are a lot of things to consider. Like when we give Depakote, generally we don't know what implications it would have. Usually we tend to avoid it in hepatic failure. And I think the IV formulations, when they're not going through the first pass effects, they may increase the risk because there's more drug in there in the system. It may increase the risk of hepatotoxicity. And I am really not sure why they have not used IV Depakote a lot. I think it's more helpful. It may be more helpful than using any of the other drugs. It does not have a lot of sedative effects as much as phenobarb or Precedex or these medications have when we talk about consults. So I'm not sure. Honestly, I think it should have been used more often than I have seen, but I have not seen it using that often as well. So to answer your third question, you're right. I did not mention phenobarbital there as well, because again, my focus of my talk was on the inpatient psychiatric units. If I would have covered a little bit more on the consults and that part, I would have included phenobarb as well. My experience with phenobarb has been rather limited. We have used it. I know that we have used IV phenobarb and IM phenobarb on 3 North a couple of times. Somewhere like doses between 60 to 70 milligrams. I'm also blanking out on the dose that we use. Is better to start off with. But honestly, in my experience, when I have used someone like a phenobarbital with some of these patients, it was not that helpful. It actually had like a paradoxical reaction to that, and they became more aggressive to phenobarb when I was using it. And I've recently used it on 3 North, so I've seen that more commonly. But that is the reason that I did not put that in my talk, because it was more targeted on the inpatient units. But these are all great questions. I wish I had some more data for IV Depakote, because I would like to use it, but we don't have that. Thank you for those questions.
Thank you for the answers, Ali. Thank you for the talk.
Any other questions?
Any other questions for Dr. Talpur?
If nobody has questions, I do have a question. Thank you again so much for the presentation. It was very valuable. Just because of a lot of our training happens in places where we're faced with these situations where we have to assess and make decisions. Lately, I think the pharmaceutical industry has sort of caught on that there's a market for this, and there's been an FDA approval for this oral Precedex film. And I don't know if you had a chance to mention that during the presentation or not. And I know, it's one of those things that technically fits fits some of the criteria we're looking for, right? A short duration of action, works instantly, achieves the desirable effect in causing sedation, but doesn't knock you out, or tranquilization, but not sedation. And I know, resources wise, the university doesn't really want to pay for it, or any other facility can afford it right now, just because of the price tag on it. Are there other substitutes that you can think of that might kind of fit that criteria too, working in the same sort of mechanism of action as like the oral Precedex?
I don't have anything specific in mind, but what I mentioned was like a buccal midazolam. I think we have less experience using that on our units, but I think it's pretty safe. It has a less number of side effects. It's pretty short acting, although it does require some rescue sedation. But I think that's one thing that we should consider when giving those to the patient. But again, we have that. We have acinapin. We have loxapine. Loxapine is more inhaled, but those are more like a rapid acting medications that we could use for this population. But again, as I said, the patient has to be receptive for all these. You cannot give like oral Precedex or midazolam to someone who's like about to punch everyone, so it becomes hard. But I think those are some of the options that you can think of. Excellent question and an excellent point about oral Precedex.
Thank you so much.
Okay, if there are no other questions, I will.
Dr. Talpur.
Yeah, go ahead.
There was just one more thing that I wanted to mention.
Mm-hmm.
So at the virtual APA I attended,
Yeah.
there was a person that I remember talked about ECT being studied like systematically in a prospective study. I don't think it's RCT. I think maybe it's open label in
Mm-hmm.
people who are demented who have agitation.
Mm-hmm.
So that might be something, worth waiting for in a few years.
Yeah, there have been some studies that have indicated its use in Alzheimer's disease with behavioral disturbances. But again, I would be waiting for ECT to see like what impacts ECT would have on this population. So we'll see how that goes.
Thank you very much, Dr. Talpur, for a
Thank you so
thorough and
much.
informative presentation.
Of course, thank